Welcome back, friends. Hope you are seriously preparing the app. Preparing the app is one. There is one big task in preparing the app. The big task is you have to sit without waking up, completing a topic. So don't wake up. Sit completely and finish one topic. So you should not get diverted. Switch off your phones and always concentrate only on the topic. Have your workbook in your hand and keep following the topic seriously. So when you follow seriously and attend the class as if you are attending a live class, this app will be definitely beneficial for you. Or else what happens? I have seen many students buying an app and they don't complete the 100% app. They finish only 20%, 30%, and they don't complete the app at all. So please use the app. By buying an app, you will not get a seat. By utilizing the app, using all the questions, only you can get a seat. Okay. So we are going to the next system on GIT, and GIT, I'm leading to my favorite topic, esophagus. Okay. So esophagus is one of my favorite topic, and not only for me, it is also a favorite topic for national board exams. Okay. So let's start with esophagus. It's a full big topic. Don't get diverted and fully concentrate on the topic as if you're attending a live class. So can you tell me what is the length of esophagus? What is the length of esophagus? The length of esophagus is 25 centimeters. Okay, the length of esophagus is 25 centimeters. It extends from cricopharynx. It extends from cricopharynx to OG junction. Cricopharynx is the most narrowest part, 13 millimeter diameter. Cricopharynx is the most narrowest part of entire GIT. It is only 13 millimeter diameter. It extends at 15 centimeter on endoscopy. Where is it seen? When you put an endoscopy, where is the cricopharynx seen? Means it is seen at exactly 15 centimeter on putting an endoscopy. So the most narrowest part of your GIT is nowhere here. The moment you swallow something, the most common site of section is exactly at 15 centimeter from incisor teeth. That is cricopharynx. Okay, that is the narrowest part, 13 millimeter diameter. Okay, the next narrowest part is arch of aorta. Okay, the arch of aorta. The next narrowest part is left bronchus. This is left bronchus. Okay, this is left bronchus, and then comes OG junction. So the narrow points can be mentioned as 15, 25, 27, 40 centimeters. 15 is cricopharynx, 25 is arch of aorta, 27 is left bronchus, 40 is OG junction. Please don't forget these four natural constrictions of esophagus. The natural constrictions of esophagus are at 15, 25, 27, 40. And esophagus has all layers except what layer is not there in esophagus. Esophagus does not have serosa. In esophagus, there is no serosa. Can you tell me the organ which does not have submucosa? Yes, gallbladder does not have submucosa. So esophagus has mucosa, submucosa, muscle layer, but there is no serosal layer. Please remember this point. Esophagus has no serosal layer. Okay, and now this is diaphragm. Esophagus pierces the diaphragm at what vertebral level? Anatomists usually used to tell VOA. The mnemonic has 8, 10, 12. The anatomist mnemonic V for IVC, O for esophagus, A for aorta. So esophagus enters the diaphragm level of 10th vertebra and enters into the abdominal cavity. It enters the abdominal cavity. So naturally and normally we have 2 to 5 centimeter of esophagus inside the abdominal cavity. The abdominal esophagus is 2 to 5 centimeter. And this is stomach here, and you can know the peritoneal pressure normally is 5 to 8 millimeters mercury. Esophageal pressure is minus 4 millimeters mercury. The thoracic pressure is minus 4. The abdominal pressure is 5 to 8 millimeters mercury. So therefore you can actually see the abdomen pressure is high. So this area will be continuously compressed. This area will be tightly compressed. And therefore this prevents reflux. So the most important mechanism to prevent reflux is increased intra-abdominal pressure. For this increased intra-abdominal pressure to act, we need at least 1 centimeter of esophagus inside the abdominal cavity. At least 1 centimeter is there inside the abdominal cavity. The abdominal pressure can be exerted. If it is less than 1 centimeter, this leads to GRD. If it is less than 1 centimeter, it will lead to GRD. So please remember, the increased intra-abdominal pressure prevents the reflux. If the length is less than 1 centimeter, you will develop reflux. Please don't forget this point. And can you tell me what is the name of this angle? This angle is known as esophagogastric angle or angle of His. Known as angle of His. Please don't forget this is esophagogastric angle or angle of His. So these are the basic anatomy points from esophagus. So all topics I will just start with basic anatomy for understanding purpose. So I hope you understand this anatomy. So the natural constrictions of esophagus are at 15, 25, 27 and 40 centimeter on endoscopy from incisor teeth. Please don't forget this point. Okay, and now coming to the investigations in the esophagus. What are the investigations we do in esophagus? So the investigation for esophagus to find out any pathology is always upper GI endoscopy. Upper GI scopy. So upper GI scopy is the investigation for most of the lesions in the esophagus. So this is done by spraying local anesthesia into the throat, and the patient will not be sedated. Most of the patient will be awake. You ask them to swallow the endoscopy, and the length of endoscopy tube is 100 centimeter tube. It is nowadays we use flexible endoscopy tube. We can use this endoscopy. This can pass up to D4. It can pass up to D4. The endoscopy can pass up to the duodenum 4th part. Okay, so the upper GI endoscopy, it can cause esophageal injury. Most common site of esophageal injury is cervical esophagus. The most common site of injury iatrogenically caused in the esophagus is in the cervical esophagus. Because we are negotiating the narrow point, we may forcibly perforate the cervical esophagus. And please don't forget this very basic thing, upper GI endoscopy. And one new investigation now with an endoscopy tip having a high frequency ultrasound probe. This is a high frequency ultrasound probe of 7 to 12 megahertz. Probe is introduced into the esophagus, and this investigation is known as endoscopic ultrasound. This has so many applications in entire surgery. Endoscopic ultrasound has so many applications. So with endoscopic ultrasound into the esophagus, stomach, we can go and examine pancreas also, stomach also, esophagus also. So in esophagus, on EUS, we will have how many layers seen? How many layers can you see on EUS in an endoscopy? So there are totally 5 layers seen like this. So the first layer is white color. That is what we say as hyperechoic. Second layer is black color like this. This is what we say as hypoechoic layer. Third layer is hyperechoic. Fourth layer is again black color, hypoechoic layer. And fifth layer is hyperechoic. So layer number 1, 2, 3, 4, 5. So what are the layers which are hypoechoic? Means it's layer number 2 and 4 are hypoechoic layers. Now tell me what are these layers? Number 1 stands for mucosa. Number 2 stands for muscularis mucosa. 3 stands for submucosa. 4 stands for muscle layer. 5 stands for Adventitia. Since there is no serosa, this is adventitia. So with this, we can find out the cancer. If there is a cancer in the esophagus, where is it infiltrating? Up to what level? We can find out. So this is EUS is the investigation of choice for T staging and also for N staging. So investigation of choice for CA esophagus, T staging and N staging is EUS. So there are 5 layers: hyperechoic 1, 3 is hyperechoic, 5 is hyperechoic. So the hypoechoic layers are nothing but muscle layers. Muscularis mucosa and muscle layer are hypoechoic, black layers. Okay. And if there is a node, the node has following 4 points. If there is a metastatic node, what are the features of a metastatic node? It will be hypoechoic. First point. It will be hypoechoic, more than 1 centimeter, well-defined border, round border, well-defined and round border is seen in metastatic node. So this aims question, what are the characteristic features of metastatic node? Hypoechoic, more than 1 centimeter, well-defined round border is seen in metastatic node. Please don't forget these points. These are the high-yield points from EUS. And at this point, I want you to remember this is the investigation of choice for T staging and N staging. Even tumors or any lesions arising from this muscle layer can be identified. For example, from here you can see what benign tumor arises from layer number 4. Benign tumor arising from layer number 4 is leiomyoma. Leiomyoma is a benign tumor arising from layer number 4. So the tumor arising from layer number 4 is leiomyoma. Please don't forget this MCQ also. So leiomyoma is a benign tumor arising from layer number 4 because it is a muscle layer. So leiomyoma is a tumor arising from muscles. So the EUS will tell you the nature of the tumor because it is arising from muscles. Like the EUS has so many applications. So these are the 2 commonly done investigations. And another investigation which we do in those days is barium swallow. So barium swallow is an investigation done for esophagus. So we will be discussing barium swallow in various topics. So barium swallow is nearly an outdated investigation, not used much commonly nowadays. But even today in the modern era, there are some applications of barium swallow I will be discussing in concerned areas. Okay. So I hope you understood the investigations. Next we go to the most important aspect of this chapter is physiology of esophagus. Physiology of esophagus and motility disorders. Physiology and motility disorders. Okay. So to understand this physiology, please focus next 10 minutes. Don't get diverted. Very important physiological point. The major advantage in a live class is you will be concentrating because this cannot be repeated in a live class. But in an app is you will be concentrating less. Thinking that if you want, you can go and rewind and see back again the video. That attitude you should leave an app. You should think the app classes as one time. You should never think of even going back and seeing again. So that means you should give that much high concentration in an app videos. Okay. So now understand this physiology in the next 10 minutes. Now this fellow is following a foot bolus. You are following a foot bolus. So this foot bolus moves in the esophagus. Moves in the esophagus by what? Peristalsis. This peristalsis is known as primary peristalsis. As you swallow, the food is moving down is known as primary peristalsis. It is normal phenomenon. It is a normal phenomenon. As you swallow, the food is moving down by primary peristalsis. And some amount of food which is reflexing or stuck up food particles are moved down by secondary peristalsis. So secondary peristalsis is not associated with swallowing. Please remember. It is not associated with swallowing. Primary peristalsis is associated with swallowing. So primary peristalsis associated with swallowing. Secondary peristalsis is clearing of food pipe. It does clearing of food pipe. That's all. Tertiary peristalsis is one which happens without any food stimulus. Tertiary peristalsis happens without any food stimulus. So this is abnormal and this is seen in motility disorders like diffuse esophageal spasm and what are the diseases where you get tertiary peristalsis? Diffuse esophageal spasm and nutcracker esophagus. So primary and secondary peristalsis are normal things I am writing on the right side and abnormal things I am writing on this side. Okay, please remember primary and secondary peristalsis are normal. Tertiary peristalsis, DES, nutcracker are abnormal. Now, another phenomenon is going to happen in the esophagus. The esophagus also has a property to contract. It will contract like this. Contract like this. This phenomenon is known as amplitude of esophagus. And the contraction will not be extending. It will be contracting for 4 to 6 seconds. That is known as duration. So the amplitude of contraction and the duration of contraction, normal value of duration of contraction is 4 to 6 seconds. The normal amplitude with which it contracts is around 40 to 80 millimeters mercury. The pressure with which it contracts is around 40 to 80 and some books say 40 to 120 also. So the amplitude of contraction is 40 to 120 millimeters mercury. And now the New Bailey has clearly removed these 2 values. These 2 values New Bailey removed and he has put another value known as in distal contractile integrity. New point from Bailey and Lau. This is an expected question. This is known as DCI. DCI is a multiplication of amplitude millimeters mercury into duration of contraction into centimeter the foot moves. So the value of DCI is millimeters mercury, centimeters second is the value for DCI. It is nothing but the same amplitude and duration what we discussed as separately is given one unique term known as distal contractile integrity and it is normally around 450 millimeters mercury centimeters second is the value of DCI. This is an expected question. So DCI is 450 millimeters mercury centimeters seconds. And DCI, now if you measure DCI, distal contractile integrity, DCI is decreased in which condition? And it is more than 450 millimeters mercury centimeters second in which condition? And it will be more than 8000 millimeters mercury centimeters second in which condition? This is expected question from Bailey and Lau. DCI will be decreased even up to 100 or 200 like that will be decreased in achalasia cardia. DCI is increased above 450 millimeters mercury centimeters second in diffuse esophageal spasm. It is increased more than 8000 in nutcracker esophagus. It is more than 8000 in nutcracker esophagus. Okay, so please don't forget the DCI values. And all of you know very well the lower 5 cm of esophagus is actually known as lower esophageal sphincter. It will be always closed at a resting pressure of 10 to 26 millimeters mercury. It will be always closed. Your LES will be always closed. If it is always open, you will have continuous reflex. So it will be always closed. It will relax on swallowing. As you swallow something, in 8 seconds, LES will relax. For example, if you swallow an egg piece, that egg piece, by the time 8 seconds it reaches the LES, it will open. This is the value from old Bailey. Now New Bailey has given a term for this also. LES, relaxation and resting pressure together is given a word known as integrated relaxation. Relaxation pressure known as what? Integrated relaxation pressure known as IRP. IRP is the integrated relaxation pressure. Please don't forget, the resting pressure is 10 to 26 millimeters mercury. As you swallow it, relax, it will swallowing. Integrated relaxation pressure is the pressure given. Now the term for this, a normal value is, it is less than 15 millimeters mercury. So as you swallow, the LES pressure should become less than 15. If it is more than 15, what is the condition known as? IRP more than 15. In otherwise, it is not relaxing, fails to relax. Fails to relax. This is known as IRP more than 15 millimeters mercury, and failure to relax is known as achalasia. Achalasia is a word given for failure to relax by a person known as Hurst. Hurst is a person who coined the term achalasia, and he used to call this as failure to relax. So the disease is clear now. Can you understand? This is a clear-cut disease. So normally everyone will have primary and secondary peristalsis. As you swallow, the food moves down primary peristalsis. The reflexed food or some food on the esophagus move down by secondary peristalsis. Tertiary peristalsis is a peristalsis which happens without any food stimulus, seen in DES and nutcracker esophagus. Amplitude and duration are the old terms for the distal contractile integrity given in billion now. The normal value is around 450 millimeters mercury centimeters seconds. If it is more than 450 millimeters centimeters second, it is DES. It is more than 8000, it is nutcracker. And this question is highly expected national board question. Highly expected national board question. In achalasia, the DCI decreases. Achalasia DCI decreases. Okay. And LES, resting pressure and relaxation are together now known as integrated relaxation pressure value less than 15 millimeters mercury. In case of achalasia, IRP is more than 15 millimeters mercury. It's all fine, but how did you find all these values? What is that investigation known as? Can you tell me? Investigation of choice to study the physiology and to diagnose the motility disorders is known as high resolution manometry. There was one conventional manometry 5 years back. In conventional manometry, we keep catheters every 5 centimeter like this. Every 5 centimeter we keep sensors. But now in high resolution manometry, we keep sensors every 1 centimeter. Totally there are 36 sensors kept in a high resolution manometry. 36 sensors kept. 36 sensors are used in high resolution manometry. With high resolution manometry, please remember, with high resolution manometry, we come to a classification known as Chicago classification of motility disorders. Please don't forget, Chicago classification of motility disorders. The name of the classification is Chicago classification of motility disorders. There are so many types. I am focusing only on the high yield types. They are hypomotility disorder and hypermotility disorder. Hypomotility disorder and hypermotility disorders. And in this, I am going to discuss in hypomotility disorder only 3 things. They are type 1 achalasia cardia, type 2 achalasia cardia, type 3 achalasia cardia are the 3 hypomotility disorders I am going to discuss. And in hypermotility disorders, there are 2 things which I am going to discuss: DES and nutcracker esophagus. So please focus. I am going to tell you what I already discussed so far. I am going to discuss what I already discussed. Okay, so now you have to remember here the types of achalasia. The type 1 achalasia is known as classical achalasia. Type 2 is not mentioned as vigorous achalasia, but the features are vigorous nature. Type 3 is spastic achalasia. So now in this file, I am going to discuss about number 1, peristalsis. About the peristalsis I will be telling for all guys, and about DCI I will be telling for all guys, and about integrated relaxation pressure I will be telling for all these people. Okay, so now let us discuss one by one. So classical achalasia, both primary and secondary peristalsis are absent. Absent peristalsis or failed peristalsis is seen in all types of achalasia. Absent peristalsis or failed peristalsis is seen in all types of achalasia. 1, 2, 3. In all cases we have, all these cases we have failed peristalsis. Okay, failed peristalsis is seen in type 1, 2, 3 achalasias. DCI now. DCI is decreased in classical achalasia. DCI is decreased in classical achalasia. It is normal or increased in vigorous achalasia. That is why it is known as vigorous. That is why it is known as vigorous. It will have high amplitude or normal amplitude. Or otherwise, there is an isobaric contraction. There is an isobaric contraction. I will show you this image. You have to remember when I am showing this image at 30 millimeters mercury level, there is an isobaric contraction seen in vigorous achalasia. And we call this type 2 achalasia is having pan-esophageal pressurization. This phenomenon is known as pan-esophageal pressurization. The exam questions will be, in which type of achalasia you have pan-esophageal pressurization is the question. In spastic achalasia, if this is esophagus, we have increased amplitude in some places like this. Some segmental increased amplitude seen, not fully, but segmental increased DCI seen. So pan-esophageal pressurization is vigorous achalasia. Segmental increases spastic achalasia. Okay. So the peristalsis. What about peristalsis in all the cases? In all the cases, IRP is more than 15 millimeters mercury and it fails to relax. In all the cases, it is same in all these achalasias. So this is a Ames question. Please don't forget this Ames question. High yield Ames question. You can easily understand. Peristalsis is primary and secondary peristalsis is seen in classical vigorous spastic achalasia. Absence of peristalsis is the first important point in all achalasias. And similarly, integrated relaxation pressure is more than 15 millimeters mercury and failure to relaxation is seen in all achalasias. So the difference between the achalasias is in the DCI. Low DCI in classic, isobaric contraction in vigorous, segmental increased DCI in spastic achalasia. Please don't forget this points. Very important for your exams. And coming to DES. Now coming to DES, same thing you have to tell. DES, there will be tertiary peristalsis. DCI will be more than 450 millimeters mercury centimeters seconds. Just now I told you. And IRP will be normal. IRP will be normal in DES. Nutcracker esophagus also tertiary peristalsis will be seen, and the DCI will be more than 8000 and IRP will be normal. So nothing to mug up if you understand the physiology and pathology of these 3 diseases. If you understand the physiology and pathology of these 3 diseases, it's very simple. Okay, I hope you understood this. One of the high yield topics, around 100 MCQs are there with this alone. In various exams, we have around 100 MCQs on Chicago classification of motility disorders. So hypermotility disorders are DES and nutcracker esophagus. Nutcracker esophagus is the most common hypermotility disorder. Most common hypomotility disorder is classical achalasia. Most common hypomotility disorder is classical achalasia. Among these 3 achalasia which have best prognosis is vigorous achalasia have the best prognosis because they have high pressure in the esophagus. So when you treat them, they will respond well. Best prognosis is seen with vigorous achalasia. Please don't forget, best prognosis is seen with vigorous achalasia. Because the peristalsis is good, sorry, the amplitude is good, so after doing myectomy, the foot will easily move down. But in other achalasias, the amplitude is not so good, the foot particles will not move properly. And now, coming to the types one by one, let me start my discussion from achalasia cardia. Achalasia cardia, let me start my discussion. One of the high-yield topics for your exam and favorite topics by your examiners is achalasia cardia, and especially for final MBBS students who are listening to this video, it is one of the important short notes, as well as sometimes it can be coming in essay question also. So it is most common in young females. It is most common in young females. It is most commonly presenting with dysphagia. The most common presentation is dysphagia. And the dysphagia will be for both solids and liquids. Many of the time the exam students confuse between the dysphasias. In achalasia, please remember there is dysphagia for both solids as well as liquids. It will be more for what? More for liquids. Otherwise there will be dysphagia for both. It will be more for liquids. If you take a solid food particle, it will go easily. But liquids will float in the esophagus itself and will not go because the LES is very tight. So please remember it is for both solids and liquids, it's more for liquids, and it is a slow progressive dysphagia. The history will be there for many years. Patient will tell, patient is living with this dysphagia for around 1 year, 3 year, 4 year, like that they will tell me. I have seen many patients coming to me with achalasia, and when I advise them to undergo surgery for this achalasia, many of them will not believe me. They won't first of all trust us, thinking that we are doing something for doing surgery, and they won't come back also. So far I have seen 20-25 cases in the past 1 year. Only 10 cases came for surgery, and 10-15 cases I don't know where they are. They have never come back because they think that is not big problem. Why this fellow is asking us to do surgery, like that they will not come. And sometimes they will have some manuals. Manuals will be explained by them. For example, some of my patients, what they will do after eating, they will stand on a tall, high table like this, and from this table they will jump down. They jump down, the foot will go down. And some people will do Valsalva manual, some people will do dancing manual, something they will do, and that will make the foot go down. So like that with manuals they will be living. Please remember. And they will have a typical dysphagia, weight loss plus regurgitation or reflex. Dysphagia, weight loss, and reflex is a triad. Not always seen, but this is a triad of achalasia. So they will have a reflex. I have missed a patient thinking it is a case of GRD and later diagnosed as achalasia and came back to me surgery from another medical gastroenterologist. So please remember, reflex or regurgitation, or even aspiration, and sometimes they can even develop nocturnal asthma. Nocturnal asthma, because after lying down, the food particles here will get aspirated and they will develop nocturnal asthma. So all these are various clinical features of achalasia cardia: dysphagia, weight loss, and reflex. And now, such an achalasia cardia patient comes to your hospital. Let us assume this is a female coming to you with a achalasia cardia. She has come to you, sir, I am having clinical features of dysphagia, weight loss, reflex, and you are strongly suspecting she is having achalasia cardia. And what are the investigations we are going to test for her? So the investigations done for a patient coming to you with a dysphagia are the following. We will usually advise barium swallow because it is a very simple test, non-invasive. Just they will take an X-ray and come back. And in a barium swallow, but it is not the investigation of choice. In the barium swallow, we find out what finding we get. This is the finding we get in barium swallow. This is known as bird's beak appearance, like a bird hanging down from a tree. Bird's beak appearance. Bird's beak appearance. There are many more appearances. What is this appearance in achalasia? Pencil tip deformity. Pencil tip deformity. So the contrast will give an appearance of bird's beak like this, or a pencil tip like this, or sometimes the contrast can flow distally from the bird's beak like this. Some contrast because of weight, the contrast can flow. This is a radiology question. This is known as Hurst phenomenon on barium swallow. So Hurst phenomenon is seen in barium swallow. Okay, so please don't forget, this is Hurst phenomenon. Following a barium swallow, the patients may have some contrast flowing down, known as Hurst phenomenon. So this is barium swallow showing Hurst phenomenon. This is bird pencil tip, and this is bird's beak. And what we surgeons use the term is abrupt cutoff of contrast. Abrupt cutoff of contrast is a term we surgeons use to make. Abrupt cutoff of contrast is a term we use. Okay, so please don't forget, these are the barium swallow findings in achalasia. Abrupt cutoff is a term actually we use. And please don't get confused with the rat tail. This is rat tail appearance. Rat tail is not seen in achalasia. Rat tail is seen in cancer esophagus. It is also known as rat tail appearance, also known as cancer esophagus appearance, also known as irregular narrowing. That is also known as irregular narrowing. That will be irregular narrowing seen. So please don't forget, rat tail is irregular narrowing, and Hurst phenomenon, abrupt cutoff, pencil tip, bird's beak, all are seen in achalasia. So cancer, you get this rat tail or irregular tapering appearance. So what other investigation I do is, I will send the patient for an X-ray, chest and an abdomen. High yield MCQ comes now for AIMS. X-ray chest and abdomen. In an X-ray chest, you will get this appearance. This is a dilated esophagus in achalasia, and this is a constricted narrowed esophagus in achalasia. This is stomach. Now the esophagus itself acts like a stomach, and the food particles and all will be remaining here itself. So the food particles will be remaining itself, and therefore you get an air fluid level. You will get an air fluid level here. You will get an air fluid level in the mediastinum. And abdomen, in abdomen, what is this? All of us will be having this. What is it? This is fundus gas shadow. This will be absent in achalasia. Please don't forget, absence of fundus gas shadow is seen in achalasia cardia. In an X-ray chest, there will be mediastinal air fluid level, about retrocardiac air fluid level, and in the abdomen X-ray you will have absence of fundus gas shadow. Absence of fundus gas shadow is seen in an abdominal X-ray. Please don't forget these 2 points. Okay, and there comes our hero. The investigation of choices always for an achalasia. The answer is high resolution manometry. Don't get confused in this. So though I am discussing other investigations first, don't get confused. Final MBBS students, you must not get confused. The investigation of choices, high resolution manometry, and on high resolution manometry we get how many types of achalasias? Types 1, 2, 3. Which is best? Type 2 is best to get. Which is most common? Type 1, classical achalasia is most common. Type 2 is best, and type 3 is spastic achalasia cardia. Okay, spastic achalasia cardia. So next, you can write the enormous points in achalasia cardia. Next comes complications of achalasia. Complications of achalasia cardia. The complications of achalasia cardia we have next. So before I'm going to the complications, I'm drawing you a classical achalasia finding. So this is the lower esophageal sphincter, which is very tight. First of all, understand this is lower esophageal sphincter, which is very tight, tightly closed. And this is the esophagus, which is dilated. Please understand this is dilated esophagus, and this is constricted part of esophagus. And in those days, there was one MCQ which is no more available now. That MCQ used to ask, in this part of achalasia, which part is having absence of ganglion cells? The part of esophagus is having absence of ganglion cells here is dilated part or constricted part was an old question. That question is nowadays totally out of books because we are not taking biopsy to do achalasia. Therefore, this question has been removed. But we have that question for this disease. What is this? Same type. There is a constricted rectum. Rectum is constricted, and this is dilated part of colon in another disease. What is that disease known as? That is known as Hirschsprung disease. So Hirschsprung disease, it is actually known as aganglionotic disease, congenital aganglionosis. In a Hirschsprung disease, this is dilated bowel, this is constricted bowel, which is abnormal. So Hirschsprung disease, the constricted part has abnormal. There is absence of ganglion cells in R-batch plexus as well as Meissner's plexus of constricted part. The dilated part, which looks like megacolon, is totally normal. According to old books, achalasia, when you take biopsy from this constricted part, achalasia, constricted part is normal. And they used to say there is absence of ganglion cells in the dilated part. Ganglion cells. What ganglion cells? There is no Meissner's plexus. There is only R-batch plexus in dilated part. But that point is not used nowadays because we are not taking biopsy in achalasia. But for Hirschsprung disease, this question will be repeatedly asked. In Hirschsprung disease, this is dilated colon, this is constricted part of colon, which is abnormal. Dilated one is not abnormal, it is normal. The constricted one is having absence of R-batch plexus and Meissner's plexus. We will be discussing this more detail in Hirschsprung disease. But understand, achalasia is just opposite. The constricted part is normal. The dilated part of esophagus has absence of ganglion cells. This concept of on Hirschsprung disease is not there now in books, so don't worry about it. Now coming to the complications, what happens? This is esophagus acting like a stomach, and this is tied lower end. Now the food particles are remaining in this place. So the most common complication of achalasia is what? Most common complication is very clearly you can see from here. They will have more of reflux, GRD, and reflux esophagitis. So that's why I told you achalasia, the presentation is reflux. Many times I have even missed one or two cases with reflux, thinking it is reflux esophagitis. So please remember, achalasia presents with reflux esophagitis, most common symptom. Most common complication, not symptom, most common symptom is dysphagia. Most common complication is reflux esophagitis. And this can go for aspiration, nocturnal asthma, they are the other complications. Now, please remember, one of the important complications I'm going to tell, because of constant irritation on the esophagus, this will lead to squamous cell cancer in 8% of the people. Squamous cell cancer is most common cancer in achalasia. It is seen in 8% of the people. Will they develop adenocancer? Yes, they can develop adenocancer in this place. What is this place? Below air fluid level. Below air fluid level. The mediastinum, at the air fluid level below, it can develop adenocancer, but it is very rare. It can develop, but it is very rare. And the esophagus can mega dilate like this. What is this? It looks like a sigmoid mega esophagus. The other complication is sigmoid mega esophagus. Sigmoid or mega esophagus is another complication. Okay, so please remember, reflux esophagitis, aspiration, squamous cell cancer, adenocancer, below air fluid level. Squamous cell cancer is the most common cancer in achalasia, and sigmoid or mega esophagus are the various complications of achalasia cardia. Now coming to the management of achalasia cardia. The management can be by three guys. Who are the three guys? One is you, a medical MBBS graduate. An MBBS person can manage an achalasia by certain methods, by means of giving medicine, by medicine treatment. And the patient can be managed by a DM gastroenterologist. You know very well, DM gastro is a course done after MD general medicine, and they are having endoscopy now in their hand. Interventional endoscopists, they are interventional endoscopists, so they can manage it by various methods like 1, 2, 3. One method is by putting one injection known as Botox injection in the constricted part, or by using pneumatic balloon dilatation method. Pneumatic balloon dilatation method. They will keep a balloon in the constricted part and they will open the balloon so that the muscles will get tagged. That is pneumatic balloon dilatation. And the last method is used in medical gastroenterology, which is a recent method. Can somebody tell me? This question is recently asked also. By endoscopy itself, they do a procedure known as POEM, peroral endoscopic myotomy. That is known as peroral endoscopic myotomy, POEM. So peroral endoscopic myotomy, POEM is done recently. That is a recent advance in management of achalasia cardia, and this is the best procedure for type 3 achalasia. Best for type 3 achalasia, the best type of treatment is POEM. Please remember, this is a future MCQ. So please remember, as an MBBS graduate, you can treat achalasia by giving medicines. What are the medicines? Calcium channel blockers, which can relax the LES. Along with the food, we take calcium channel blockers like nifedipine or sildenafil citrate. Sildenafil citrate, you all know it is Viagra, which is also used here. CC, calcium channel blockers, sildenafil citrate are medical treatment which have 60% response. Some around 60% response. When the patient goes to a DM gastroenterologist, they have endoscopy, and with the help of endoscopy, they put Botox injection, they do pneumatic balloon dilatation, and they can do POEM. Please don't forget, POEM is a recent advance in achalasia cardia. And when the patient comes to a surgeon or a surgical gastroenterologist, who is MCH, surgical gastroenterologist, if the patient comes to us, that is the gold standard treatment. What is it? Gold standard treatment of achalasia is what? Modified Heller's cardiomyotomy. Modified Heller's cardiomyotomy. Modified Heller's cardiomyotomy is the gold standard treatment done by us. What is this procedure? Please understand what we do in this procedure. By laparoscopy, by putting a laparoscopy, I go inside and I cut the muscle alone like this. Cut the muscle. I will not go and cut the mucosa and submucosa. I will cut the muscle 1 to 2 cm below O junction to 6 to 8 cm above O junction. The muscle will be cut like this. We cut the muscle, the constricted part of the esophagus, the muscle will be cut. Once you cut the muscle, naturally you all very well know, this part of esophagus becomes dilated like this. So this is known as modified Heller's cardiomyotomy. I would like to warn you, my class will be a little fast and every point is more important in this. So if I tell some point, sometimes I will not repeat that point. Means if I am not repeating, it may be asked in exam, but not previously asked. So please remember, this value 1 to 2 cm below O junction, 6 to 8 cm above O junction is not asked for PG entrance exam, but is asked in super specialty. So with the upcoming next pattern and all, we can get more depth questions. So I wanted to tell you this. So after doing this modified Heller's cardiomyotomy, what is the most common complication? Most common complication of this procedure. After doing this procedure, the patient will develop one complication, that is GRD. Now the sphincter is gone, so there will be more reflex. So what I should therefore do? Therefore, to prevent reflex, I will also do a partial fundoplication also. So can you tell me what fundoplication I will do in this? The partial fundoplication is DAR. I will discuss about it later. DAR's fundoplication I will do. So DAR's type of partial fundoplication will be done by me. So please understand these are the treatment of achalasia. So medical treatment, endoscopic treatment, and surgical treatment. The gold standard treatment in the presence of poem, even though there is poem coming up now, even with poem in presence, we are having modified Heller's cardiomyotomy is the gold standard in which we do anterior surface myotomy. Those who want an extra edge, if I am doing myotomy, I perforate the esophagus, perforate or open the mucosa. What I will do? If I do myotomy and I have done a perforation of the esophagus, I will close the rent of mucosa alone. I will close the rent of mucosa alone and do a fundoplication, which will not only act to prevent reflex, it also acts as a buttress on the opening. For example, I made a hole here. Over the hole, this will act as a covering. So perforated cases, while doing surgery, I will do this. And those who want an extra edge in an achalasia, please remember, post-treatment of achalasia, we have a scoring system known as, what scoring system is it? Eckert score. The scoring system post-treatment is known as Eckert score. So please remember the name alone. There is a score known as Eckert score after treatment of achalasia. So how the response is, based on the response, we will decide whether the treatment is successful or not. I hope you understood achalasia cardia. Achalasia cardia is an important short notes for essay question for final years, and it's an important high yield topic for PG aspirants. Okay, please don't forget these points from achalasia cardia. Okay, so now let me go to the other two motility disorders, diffuse esophageal spasm and nutcracker esophagus. Let me discuss some basic points in this. Already we have discussed the manometry findings. Let me discuss the other points. So DES, diffuse esophageal spasm and nutcracker esophagus, which is most common? Nutcracker is most common. DS is common in middle-aged female. Middle-aged female develops DES. Nutcracker is most common in, there is no special sex. It is equal in male and female. This is an MCQ. It is equal in male and female, and it can happen at any age. Any age it can happen. So DES, they present you with a clinical feature of dysphagia along with chest pain. They will develop dysphagia with chest pain. They come to hospital. Nutcracker esophagus presents with a clinical feature of mimics like MI. This is a typical case. Mimics like MI. Myocardial infarction. They develop severe retrosternal discomfort. They get admitted in ICU. In ICU, they spend a lot of money for all investigations like angio, troponin, everything will be done and everything will be finally normal. And the same patient will be referred to a gastroenterologist. And when the patient comes to us, he will tell, sir, I have spent a lot of money in cardiology, but please do something cheaper. So the treatment is also very cheaper treatment for them. The only treatment of nutcracker esophagus is calcium channel blocker. That's all. No surgery advice for them. There is no surgery. We will advise them only calcium channel blockers in the case of nutcracker esophagus. This is a classical history of every nutcracker patient. Please remember, every nutcracker will have this history. They will be admitted in ICU, treated in ICU, they come to us finally with no packet money, and they will be diagnosed on manometry, and the treatment is just calcium channel blockers. In a DES, there is typical history of aggravation with what? What are the factors which aggravates DES? Aggravated by cold fluids, stress, some stress or drinking of cold fluid will aggravate DES. So DES is easily prevented by avoiding cold and stress. And if it happens, we should give them calcium channel blockers as a treatment. In extreme cases, we can also do surgery. The surgery is known as what? This question is expected question. For your next exam, this is expected question. Long esophagomyotomy. In case of achalasia, how long did we did myotomy? About 6 to 8 cm. But in this condition, the esophagus will be like this. We have to do myotomy like this up to bifurcation of trachea known as carina. Up to carina, we do myotomy. Please don't forget, up to carina, we do myotomy in these cases. So, point is, long esophagomyotomy is done. Barium swallow of these two cases. What are the findings? Barium swallow of DES will have, what is this finding? I'm going to show you this image. This is corkscrew esophagus. DES will have corkscrew esophagus, and nutcracker will have this type of diverticulum in the lower esophagus. They are known as pulsion or epiphrenic diverticulum. Pulsion or epiphrenic diverticulum is seen in nutcracker esophagus. DES will have corkscrew esophagus. This fellow will have pulsion or epiphrenic diverticulum on a barium swallow. So now let me show you the images of what we discussed so far from PowerPoint. Please understand the images, high yield image questions. You can see this is the normal esophagus length is 25 cm, zero size absent. The natural constrictions are at 15 cm, 25 cm arch of aorta, 27 cm left bronchus, 40 cm OG junction are the natural constrictions. And you can see this is a normally done endoscopy by myself in my clinic. You can see I am putting an endoscopy just going behind the tryptopharynx. So now let us discuss the other rare motility disorders. They are diffuse esophageal spasm and nutcracker esophagus. We are going to discuss few points from these two. From these two, few points we discuss. Okay. So nutcracker and diffuse esophageal spasm both are very rare disorders, but in spite of they being rare, the most common hypermotility disorder is nutcracker. Please remember, nutcracker is also known as jackhammer. Bailey used to say this as jackhammer. Jackhammer esophagus. So DES is most common in middle-aged woman. Middle-aged woman, it is common. Nutcracker, it is equal in male and female, and it can happen at any age. There is no sex prediction or age prediction. So it can happen in any of them. Any age, any sex, it can happen. And DES. So please remember, DES, the most common presentation is dysphagia associated with chest pain. Dysphagia with chest pain, and always there will be some history of aggravation of this dysphagia and chest pain following a drinking of cold liquids. Following drinking of cold liquids or following a stress. So stress and cold liquids will aggravate DES. But nutcracker esophagus, it is not like that. So nutcracker esophagus is associated with more of chest pain. It mimics like MI. It mimics like MI. Please remember, it mimics like MI. And these patients get admitted in coronary care unit. They will be spending lots and lots of money, even on angio, troponin, everything would have been done. And the patient would have spent around 2 to 3 lakhs rupees before coming to our hospital. And the moment they come to the hospital, they will tell, sir, I have gone so here and there, I have spent so much money. Please do some budget treatment like that. They will ask, and the treatment itself is very budget treatment only. The only treatment for nutcracker is calcium channel blockers. No surgery advised for nutcracker esophagus. Only treatment is calcium channel blockers. Similarly, for DES, the treatment of choice is calcium channel blockers. And if sometimes we do surgery, not always. Sometimes we do a surgery known as long esophagomyotomy. Long esophagomyotomy. I hope you remember in modified Heller's cardiomyotomy, we did myotomy up to how many centimeters? Up to 6 to 8 centimeters. In this case, we do long esophagomyotomy up to carina level. Up to carina level. So please remember, barium swallow finding of these two. Barium swallow of DES looks like this. What is this appearance? It looks like a corkscrew esophagus. Corkscrew esophagus. barium swallow of nutcracker esophagus will have this appearance. They are known as epiphrenic or pulsion diverticulum. Epiphrenic or pulsion diverticulum. They are known as epiphrenic or pulsion diverticulum. They are actually false diverticulum due to high pressure of manometry, TCA value being 8000. The compression of the esophagus mucosa causes them to bulge out like epiphrenic or pulsion diverticulum. So I hope you understood the motility disorders. Let me show you the images of all the points we just now discussed. Okay, so please understand the images. So the natural constrictions in esophagus are at 15 centimeter, 25 centimeter arch of aorta, 27 centimeter left bronchus, 40 centimeter OG junction. Okay, please don't forget this anatomy. And I'm showing you an endoscopy of mine. So you can see that's a trachea anteriorly. I'm going posteriorly. I'm having difficulty in negotiating the cricopharynx. With difficulty, I'm entering the cricopharynx. Now I have entered the esophagus. Therefore, the most common site of operation is cervical esophagus. Now you can see I'm going inside. I will be passing all the natural constrictions like arch of aorta, bronchus, and you can see this is cardiac beat, and this is OG junction, and you can see the Z line. Z line is a line between squamous epithelium and columnar epithelium. So this is a normal endoscopy of the esophagus. Okay, normal endoscopy of the esophagus. So how many layers are there in EUS? There are totally 5 layers, and which layers are hypoechoic means please don't forget muscularis mucosa and muscularis propria are hypoechoic layers. So this is a lymph node which is again hypoechoic, more than 1 centimeter round border. Okay, you can diagnose. The T staging is best diagnosed with this EUS. With the endoscopic ultrasound, T staging is diagnosed, and this is a classical type of bird's beak appearance. You can see, please don't forget these type of images. You should never forget in your lifetime. Okay, this is bird's beak appearance, and this is corkscrew esophagus, and this is the barium. Sorry, this is a manometry finding. You can see as the patient swallows, the food is moving in the esophagus. This is normal peristalsis, and this is LES. So this is a normal high resolution manometry finding. And these are the achalacias. In type 1 achalasia, there is no peristalsis, no amplitude also. So type 1 achalasia, you can see from the first image. I told you in type 2 achalasia, there will be pan-esophageal pressurization or isobaric contraction at 30 millimeters mercury. You can see in this image. Definitely for PG aspirants, this will not be asked as an image-based question. But for super specialty aspirants, this can be asked as an image-based question. So please remember 30 millimeters mercury, that is isobaric contour. And type 3, you can see segmental increased amplitude. Segmental increased amplitude is seen in type 3 achalasia. So type 1, type 2, type 3 achalasia. Okay. So these are the points we discussed regarding the Chicago classification. And this is what phenomenon? From the bird's beak, there is contrast flowing. This is known as Hurst phenomenon. Please don't forget this is Hurst phenomenon. Okay, so next we are going to the next important topic on diverticulum in the esophagus. I hope you understood the physiology and motility disorders. Let us now start with diverticulum in esophagus. Now a small topic but full of MCQs. Please focus. Diverticulum in esophagus. So this is esophagus. All of you know very well. This is a anatomy I'm going to draw here is cricopharynx muscle. This is cricopharynx muscle. Cricopharyngeus muscle. This is a midline. And this is another muscle. What is the name of this muscle? This is a muscle in the inferior constrictor of pharynx. So this is one side and this is the other side. What is the name of this muscle? This is thyropharyngeus muscle. Between thyropharyngeus and cricopharyngeus, you can see there is a triangular gap on both sides. What is this gap? This is known as Killian's triangle. This is known as Killian's triangle. So Killian's triangle is a triangular divide between cricopharynx and thyropharynx of inferior constrictor muscle of pharynx. And this is a weak area. And through this, if the mucosa bulges out like this, it is known as pharyngeal pouch. Pharyngeal pouch, also known as Zenker's diverticulum. Zenker's diverticulum or pharyngeal pouch is a defect in the Killian's triangle. Please don't forget it is a defect in the Killian's triangle. Okay, this is one diverticulum in the esophagus. In the middle of the esophagus, you can get diverticulum more common on the right side due to traction by the nodes near the vertebra. By the traction by the nodes near the vertebra, they are known as traction diverticulum in the middle of esophagus. And already I discussed one diverticulum in the lower part of esophagus, in the lower 10 centimeters, known as epiphrenic diverticulum. Epiphrenic, also known as pulsion diverticulum, is seen in the lower part of esophagus. These are the 3 diverticulums seen in the esophagus. In this traction diverticulum is the only true diverticulum. All other diverticulums are false diverticulum. Only traction diverticulum is true diverticulum. Zenker is false diverticulum. Epiphrenic diverticulum is also false diverticulum. I hope you know what is true and false. True diverticulum is a diverticulum which is containing all layers like mucosa, submucosa, muscle layer. False diverticulum is a diverticulum which does not contain muscle layer. So diverticulum does not contain muscle layer. Okay, so please don't forget these 3 headings. Now let us discuss one by one in detail. So you all understood this is a cricopharynx muscle. Cricopharynx muscle is given another name known as upper esophageal sphincter. It is given another name known as upper esophageal sphincter. It will relax only for 2 to 4 seconds during swallowing. As you swallow, only 2 to 4 seconds it will relax and it will be closed at a resting pressure of 40 millimeters mercury. The resting pressure of this is 40 millimeters mercury. It will be tightly closed. It will relax only 2 to 4 seconds. Now, in old age, what happens? In old age, especially old age men, more common in men, those who are having neurological disorders like Parkinson or some other neurological problems, this cricopharyngeal muscle will go for spasm, also known as cricopharyngeal achalasia, So therefore, if a patient tries to swallow something, a cricopharynx will not open up, and therefore there results a diverticulum through the weakest area, that is Killian's triangle. Through the Killian's triangle, the diverticulum bulges out. The diverticulum is most commonly seen on the posterior triangle. Posterior triangle behind sternocleidomastoid, most common on left side on the posterior triangle. So now can you tell me what is the most common presentation this old man comes to hospital? The most common presentation this old man comes to hospital is dysphagia. So dysphagia is the most common presentation of this old man. As he swallows, the food will get stuck up in the neck, and the most common complication he will develop is because of the food getting stuck up, he will aspirate. Aspiration is the most common complication. So complication is aspiration, symptom is dysphagia. Please don't forget these points. The most common symptom is dysphagia, most common complication is aspiration. And when such patient comes to you, what is the investigation of choice? Investigation of choice is a lateral X-ray of barium swallow, lateral oblique view. When you take barium swallow, you can see the Sencus diverticulum. Sencus diverticulum can be seen, and you can see the contrast is going very difficult to the cricopharynx. Most of the contrast coming into the diverticulum is seen on this case. So the treatment is therefore many types of treatments available for this case again. Let me tell you the first treatment of choice. What is the treatment of choice for these cases? Sencus diverticulum, treatment of choice is surgical. Surgical treatment of choice, what we do is, like in achalasia, please observe here, we will cut this muscle. We will cut this muscle. What is the surgery known as? Because that is having spasm that is causing this problem. So the first step you should do is cricopharyngeal myotomy is done. So cricopharyngeal myotomy is done first. Along with this myotomy, we should cut and remove the diverticulum. We should cut and remove the diverticulum. So the treatment is cricopharyngeal myotomy with diverticulectomy is the gold standard treatment for achalasia. In fact, Sabiston writes, if the diverticulum is less than 2 cm, cricopharyngeal myotomy alone is enough. If it is very small diverticulum here, less than 2 cm, once you do myotomy itself, the diverticulum will disappear according to Sabiston. The treatment of choice, if they don't mention any size, go for cricopharyngeal myotomy plus diverticulectomy. Okay, this is the ideal surgical treatment. And there is one more treatment again as usually done by medical gastroenterology guys. The medical gastro guys, they have a special treatment in which they pass stapler inside like this. They pass a stapler through the one limb into the esophagus, another limb into the diverticulum, and they will staple like this. Once they staple like this, the diverticulum which is looking like this will become like this. So thereafter the food particles will not go and stay there. They will go like this and come inside like this. This procedure of endoscopic stapling technique is known as, what is the name? Endoscopic stapling technique is known as Dollmann's operation. Dollmann's operation. Please don't forget the name. Dollmann's operation is an endoscopic stapling technique. High yield MCQ. An interesting point in this is this Dollmann's operation can be done only when the diverticulum size should be more than 3 cm. So indication is if the diverticulum more than 3 cm. Contraindication is for less than 3 cm and for people who cannot open their mouth. Some people have tight mandible, they cannot open their mouth. If unable to open the mouth, this procedure cannot be done. They have to open mouth wide open, then only we can put the stapler. They are unable to open mouth wide open, then like Christmas patients, we cannot do this. So contraindication is less than 3 cm and unable to open the mouth, or contraindications for Dollmann's operation. There is one more operation also available, which is done for very old and fragile patients. For very old and fragile patients, there is one more treatment. Very old, fragile patients, there is one more treatment that is known as, if this is the diverticulum like this, we make the diverticulum like this. We will make the diverticulum ulta, from looking down, we make it looking up, and we fix it to the prevertebral fascia. We fix it to the prevertebral fascia, the diverticulum is fixed. Some books also say this is also fixed to pharyngeal wall, posterior pharyngeal wall. But ideal answer will be prevertebral fascia. The strip will be fixed there. So there is no chance of leak, and the food particles now will not go up like this, they will go down like this only. But this is not always the treatment of choice. Diverticulopexy is reserved only for very old, fragile patients. Just you make dissect it and make it ulta. We don't cut, we don't do suturing, etc. Just fix it to the prevertebral. We make it like this and fix it to the prevertebral fascia is the treatment for this diverticulum. So please don't forget, Sencus diverticulum investigation of choice is barium swallow, and Sencus diverticulum Dollmann's operation is done by endoscopy people only for diverticulum which are more than 3 cm. Less than 3 cm it is not useful. Less than 3 cm it is not useful. It is useful only for more than 3 cm size. And coming to the middle esophagus, we discussed there is a diverticulum due to nodes, satiating nodes in the vertebra. They are known as tuberculous nodes in India, or due to histoplasmosis in Western countries. So the most common cause of true diverticulum in the middle of the esophagus is due to satiating nodes. This is a traction diverticulum. So traction diverticulum. So for traction diverticulum, we don't do resection, and the treatment of choice for huge traction diverticulums is only diverticulopexy. We only do diverticulopexy for traction diverticulums. Okay, so traction diverticulum, we just only do diverticulopexy. An interesting line from Sabiston is, even in the middle of the esophagus nowadays, this type of traction diverticulum is less common. We are getting more and more of pulsion diverticulum due to motility disorders. So today, pulsion diverticulum due to motility disorders are more common diverticulum in the middle also. Is a line from Sabiston. So previous 10 years back, the most common diverticulum in the middle of the esophagus is traction diverticulum due to TB. But now this is totally replaced by this pulsion diverticulum. So pulsion diverticulums are seen in hypermotility disorders like nutcracker, TES. So just remember, they are seen in hypermotility disorders. They will be seen anywhere in the esophagus. More common in the last 10 cm. Most common site of pulsion diverticulum is in the epiphrenic area, means above the diaphragm. Last 10 cm is most common site of the pulsion diverticulum. So let's see the images now from the diverticulum. So see the images. So this image showing you puck up, barium swallow, lateral oblique view, showing the diverticulum here. Sencus diverticulum, barium swallow is investigation of choice, and you can see we are doing a diverticulectomy operation in this. And this is the Dollmann's procedure. What is the procedure done here? Maybe asking an exam. This is known as Dollmann's procedure, in which we are stapling the esophagus and the diverticulum together. So this is Dollmann's procedure, indicated only for size more than 3 cm. Less than 3 cm, the limb will not enter inside. Okay. And this is a traction diverticulum, which is pulling it near the vertebra. It is seen in TB and histoplasmosis through diverticulum. This is only true diverticulum in the esophagus. And this is what I'm telling you, epiphrenic or pulsion diverticulum. You can see the diverticulum is bulging out in the lower 10 cm of esophagus. This is epiphrenic or pulsion diverticulum. Okay.